Good afternoon, everyone. Thank you so much for joining us for this webinar today. My name is Vicki Ellingrod, and I am the Senior Associate Dean in the College of Pharmacy and also one of the co-leads for the Education Work Group in Precision Health. Today is our second webinar in an educational series that's designed to connect clinicians and healthcare professionals with concepts key to understanding the role of the learning health sciences, artificial intelligence, and machine learning in clinical care. The overall title for our series of webinars is called Demystifying the Data Processes and Tools that are Changing Clinical Care. Before I introduce our outstanding speakers for today, I wanted to provide you with some information about precision health in case you're not as familiar. We're focused really on improving and advancing discovery, treatment, and health. With those objectives in mind, over the last 3 years, Precision Health has built new and innovative infrastructure that supports interdisciplinary research across the entire University of Michigan campus. If this is something that interests you, I highly recommend that you become familiar with our analytics platform, which was developed to help researchers and clinicians from all disciplines and all levels access and use precision health data. We also have unique data sets that can enrich many research projects involving health topics. More information about this platform can be found on the Precision Health webpage. Yet, we know as clinicians and as researchers that research that doesn't make its way into the clinic cannot improve our overall health. The Precision Health Implementation Work Group has really been working on translating findings into practice, and currently they're working on translating some of the research findings on issues such as C. diff, mental health, and COVID. Again, if you head to the Precision Health webpage, you'll be able to find some of this work highlighted there. Each year, though, we also provide the U of M community and others opportunities to learn more about precision health through webinars such as this one, symposium like the one that we have planned for 2022, and more recently through a First in the Nation Precision Health Certificate Program. This program is open to graduate and professional students across U of M's entire campus. We are currently enrolling students into the program for the winter semester, and applications are due on December 1st. You can find out more information about this program on the Precision Health website. If you're interested in precision health, we invite you to become a member so that you will be receiving information about everything that we are doing through our newsletters. We now have over 220 members, and everyone is able to use resources related to precision health, get communication to support their own work, and enjoy other benefits. More information about precision health can be found at precisionhealth.umich.edu. Before I introduce our speakers, I wanted to give everyone a quick overview of the agenda. We're going to have 2 speakers today, and they have asked that they speak, and then at the end of when they are done speaking, we will have a question and answer period. I do hope that you will take full advantage of our question and answer period because our speakers are eager to answer any questions that you may have. If during any time during the presentation you have a question, please feel free to type your question into the Q&A box, and at the end, I will be moderating the Q&A session with them to answer all of your questions. As I mentioned at the beginning of my remarks, that this is a seminar series, and this is the second of our webinars that are part of this series. If you missed our first seminar but are interested in learning more about this topic, a recording of that webinar is now available on our Precision Health webpage under the Events tab. Again, you can go to precisionhealth.umich.edu to find out more. I'm very excited about this webinar series and so glad that many of you are interested in it as well. The series was originally developed in collaboration with Dr. Cornelius James from Michigan Medicine, as well as getting input from all of our members of our Precision Health Educational Work Group. We have 2 outstanding speakers today who will be speaking about their perspectives on the topic of first doing no harm, understanding machine learning and the artificial intelligence behind clinical decision alerts. Our first speaker today is Dr. Maggie Makar, who is the first presidential postdoctoral fellow in the College of Engineering's CSE department. Her research focuses on machine learning, causal inference, and the intersection between the two. Her research is characterized by a dual focus on advancing both the fundamental science of statistical learning methods and making progress on real-world problems, especially in healthcare. Our second speaker is Dr. Karandeep Singh, who is an assistant professor of learning health sciences in internal medicine and urology and information at the University of Michigan. He is also the co-lead of the Precision Health Implementation Work Group. Dr. Singh's research spans multiple clinical domains, including nephrology, urology, emergency medicine, obstetrics, and ophthalmology. Among many other activities, he also chairs the Michigan Medicine Clinical Intelligence Committee, which focuses on the implementation of machine learning models across the health system. Again, as a reminder, if you have any questions while our speakers are giving their presentation, please feel free to type them into the Q&A, and we will be discussing them at the end. And with that, I would like to turn this over to all of our speakers. Thank you.
Thank you, Vicki. I'm going to, let me start sharing my screen. Here we go. I believe you should now be able to see my screen. Maybe a couple edits here. Okay, cool. It's always exciting to talk to people who are interested in the intersection between healthcare and machine learning or AI. So I'm really excited to be here with you today. So I think a good place to start is sort of a lexicon to explain the different buzzwords and place them in context of each other. So what is artificial intelligence? Artificial intelligence is the collection of algorithms. And you can think of an algorithm as a set of steps or procedures that a computer takes. And these algorithms are designed to mimic something similar to human intelligence. Some examples of artificial intelligence algorithms include Boolean or fuzzy logic, and you'll find these incorporated in things like kitchen appliances, for example, and roughly speaking, that kind of artificial intelligence looks like a set of rules that are encoded in the system. For example, your friendly rice cooker might have a deployed AI system, and this AI is a set of rules that look something like what you see on the slide. So one rule could be, okay, if you're cooking brown rice and this much water is left in the cooker, or heat is 100 Fahrenheit, then maybe stop cooking. And many similar rules might be a part of the system. So what happened here is a human being at some point, maybe based on experimentation or maybe just by virtue of being a really good cook, decided that these rules are the right things to do to get perfect rice. Now, this is different from the kind of artificial intelligence that we see more commonly today, which is machine learning. What distinguishes machine learning from other forms of artificial intelligence is that we don't know a priori what a good rule is. And instead, what we do is we rely on data and learning algorithms to come up with a rule. And we refer to these rules as models. To draw a direct analogy to the rice cooker example, imagine a world where nobody knows how to make good rice. What we do here is we'd collect data about heat and water settings for different rice types, and maybe we also collect information about the weather on the day that we did the cooking and the final outcome. So for example, was the resulting rice cooked well? Was it undercooked? Was it burnt? And then we present this data to a computer, and we let the computer learn and tell us what is a good rule for cooking good rice. Now, if I was giving this talk maybe 10 years ago, I might have stopped here. But in recent years, a specific type of machine learning has been more or less like taking over, and that is deep learning. Deep learning is a type of machine learning where we can learn arbitrarily complex rules. This isn't to say that there is no other type of machine learning that can learn arbitrarily complex rules. It's just that deep learning, for some reason, has had very good empirical success in the last 10 years or so. So what are these machine learning tools and how do we use them in a clinical setting? We're going to talk about three main types of machine learning tools and examples of how they've been used in a clinical or healthcare application. I've laid things out in a table so it seems as if it's a one-to-one mapping, which is not true, meaning you can use supervised learning to understand disease progression or unsupervised learning to do risk stratification. Reinforcement learning is a different beast of its own, but we'll get to that in a bit. So it's not that interchangeable with the other two methods. The first tool, supervised learning, is a set of machine learning algorithms that we typically use for diagnosis and risk stratification. I think what diagnosis is relatively self-explanatory, but risk stratification refers to dividing the population into subgroups based on their risk of experiencing adverse outcomes. And the idea here is that we want to predict if something will happen in the future based on currently observable patterns. And the ultimate goal here is we want to maybe design preemptive targeted interventions to prevent those adverse outcomes. Supervised learning tends to be the most common and I think the most straightforward type of machine learning, which is why I'm going to start with that. It refers to the set of learned rules that we create using data that has labels. So the objective of supervised learning is to create a mapping or a model that takes us from some inputs X onto the outcome Y, or the outcome or the label Y. When we develop these models, the ingredients that we need are both the inputs and the outputs, so both X and Y at development time. And then at deployment or testing, we only need access to the inputs X, which we use in combination with the learned mapping that we got from the development phase to impute the corresponding outcome or label. A lot of this will become clearer as we talk about examples. So I've picked a bunch of examples to get into, and I picked them to explicitly highlight the diversity of the kind of data that we might use in these settings. So the first example of supervised machine learning models for stratifying patients who show or who come to the ED, and we want to stratify them according to their risk of developing a sepsis infection. In this example, the authors used as inputs clinical charts and more specifically ED triage texts, in addition to other structured data like vital signs and other electronic health record data. So the goal of this kind of model would be to identify patients who might be at a high risk of sepsis. And these patients, instead of being discharged from the ED, they would be admitted as inpatients. In another example, authors developed machine learning and specifically deep learning models to detect arrhythmia using ECG signals. And this is an example of a diagnostic tool, since here they weren't trying to preemptively predict something that might happen in the future, but rather they were trying to identify something that might already exist. In my own work, we've developed models that take in data from Medicare claims and predict unexpected deaths, which we define to be deaths within 14 days of an ED visit. And the idea here is we wanted to stratify populations according to their likelihood to be sort of like wrongfully discharged. And in a clinical setting, this would translate into something like an alert system that maybe says, hey, this patient is at a high risk of dying if they are discharged, so maybe admit them or put them under observation. For the last example, we'll do a deeper dive. In this example, the authors used imaging data, and specifically they used retinal fundus photographs. In this work, what they did is they, US licensed ophthalmologists labeled images as either having no, mild, moderate, severe, or proliferative diabetic retinopathy. And that's how they got their labels, their Ys. And using a specific kind of deep learning, they were able to achieve an AURC of 0.99. So it's very high, so it's obviously a very good model. In this specific type of deep neural networks is called convolutional neural networks, or CNNs. And because this would not be a proper introduction to machine learning in the year 2021 if I do not include an image of a CNN, I am flashing the schematic that represents what these models do. I won't go into the details, but I think for the purpose of an introduction, it is sufficient to know that a CNN is a kind of neural network that is able to capture spatial patterns really well, spatial patterns and shapes, if you want to think about it that way. So it is particularly well suited for images or image inputs. And one way to understand what these convolutional neural networks are doing is that they identify meaningful patterns in the photos and automatically create features based on these patterns that are then used for the prediction task. To give you an idea of what these learned features might look like, in different work, authors use retinal fundus photos to predict different cardiovascular risk factors. And what they did is that they looked at which features the convolutional neural network decided were relevant when predicting different risk factors. This kind of technique is called saliency maps. It's sort of like looking under the hood of what the model is actually learning. So on the left side here, you see the original photo. This is our input X. The middle photo shows which features were deemed relevant by the model when trying to predict systolic blood pressure. So interestingly, you'll see blood vessels are being highlighted. And in the rightmost photo, it shows the optic disc and the macula as the features of the model learned to be relevant when predicting gender. I think the important thing to note here or to remember is that the model was only given the photo and relevant label at development time. And the relevant label for this middle part was the systolic blood pressure, and here it was gender. We never explicitly told the model that vessels were a meaningful structure, for example. But in trying to predict systolic blood pressure, the model learned that blood vessels are meaningful. And when the label or the signal changed to another signal, which is here gender, it learned different structures like the macula were meaningful. All right, so this was a whirlwind tour through supervised learning. What about unsupervised learning? Unsupervised learning is a set of learned rules that we create using unlabeled data. The objective of unsupervised learning is to create meaningful clusterings or groupings of the data. Think of it as dividing the data into subgroups or groups that look similar to one another. For unsupervised learning, the inputs are the same at development and deployment. And similar to supervised learning, this X can be whatever. It can be sensor data, clinical text, claim data, almost anything. So how can this be useful in a clinical setting? I think the most common example of using unsupervised learning in a clinical setting is situations where we have a sort of like suspicion that a specific disease is actually a combination of related subgroups of diseases. In these cases, we can use tools like unsupervised learning to find meaningful subphenotypes of a disease. For example, unsupervised learning can help us say something like, okay, you know your patient is on the autism spectrum, and that's sort of an umbrella disease, but actually he or she has this specific kind of autism that is characterized by seizures. So you can maybe adjust your patient care plan to take this into consideration. Now, this animation, I think it should be showing on your screens. It shows us one of the more common unsupervised learning techniques in action. Here, X, or our input data, is two-dimensional, so you can imagine it being like one comorbidity on the X-axis and a different comorbidity on the Y-axis. And the algorithm is trying to find the best clustering or grouping of the data. And again, I think things become a bit more obvious when we start talking about examples. And the example that we'll look at here, the authors used phenome-wide association studies, or PheWAS, based on the aggregation of ICD-9 codes from electronic health records. And they used these aggregations as inputs to a specific type of unsupervised learning algorithm to identify distinct trajectories of patients on the autism spectrum. And they found 3 distinct patterns of medical trajectories, which may point to different disease etiologies. The first subgroup in this table suggests that the first subgroup is characterized by seizures. The second subgroup was characterized by multi-system disorders like GI disorders and auditory disorders. The third group was characterized by psychiatric disorders. And the different subgroups had different trajectories over time. So for example, subgroup 2 had multi-system disorders. So you see on the left plot, they had a lot of ear infections that were diagnosed early on in life, and they had cardiac disorders that spiked later in life. But what was most characteristic of that group is that they just had the largest number of coded diagnoses. Subgroup 3, which you see on the right side of the slide, was more characterized by psychiatric disorders, and their diagnoses came later in life compared to subgroup 2. So the conclusion here is that unsupervised learning might help us learn something new about disease subtypes, which might lead to different care plans for different subgroups of patients. The last major type of machine learning is reinforcement learning. In my opinion, this is the harder of all of them, especially in clinical settings. And it is a little bit distinct from the other 2 types because it achieves a more specialized set of functions, meaning we really shouldn't use it or don't usually use it for risk stratification, and we probably would not use it for understanding disease progression or disease subtypes. So it's kind of like specialized for the purpose of suggesting treatment. We define reinforcement learning as the set of machine learning methods that learn optimal sequences of actions to optimize long-term outcomes. And I'm going to present this kind of machine learning a little bit differently from the others, because the way that it is most commonly used in the literature is different from how it is used in a clinical setting. So I'll quickly talk about what it typically looks like in the general machine learning literature, and then I will present how we modify it for clinical settings. The most common form of reinforcement learning is called online reinforcement learning, where we have an agent, and this agent can be a robotic arm, but it can also be a player in a video game. And the agent observes a state, and then it interacts with the environment. And the environment here, you can think about it as the universe as the agent sees it. The way that the agent interacts with the environment is by taking an action. And as a response to this action, the environment will give the agent a reward, and it will give the agent a new state. And then given this new state, the agent will decide on a new action, and the cycle continues. When the agent is deciding on which action to take, it has to balance between exploiting actions that it has learned are good and exploring new actions which may be good, but also may be catastrophically bad. And based on this cycle, the agent learns what actions and state combinations lead to good rewards. One very famous example of this kind of learning is AlphaGo, where a bunch of Google folks are trained a reinforcement learning algorithm to play the game of Go. And as this quote suggests, the agent starts with no knowledge at all about the game of Go. And then it goes through these cycles that I described in the previous slide to teach itself how to play Go. And within 21 days, it was able to reach a level of mastery, beating professionals and even beating the world champion. I will also say here that to appreciate why this is a feat of machine learning, you have to understand that the set of possible actions for Go is huge. So enumerating all of them and greedily trying each policy would take forever. So the fact that this agent learned in finite time a good game strategy means that it was able to learn something intelligent. And there's actually a documentary about this specific kind of work if you're interested in sort of a more dramatic viewing of this algorithm. Now, the problem is that in a clinical setting, we cannot just experiment on patients and see what happens to their states under like arbitrary interventions or arbitrary actions. Instead, we have to train our agent using observed trajectory as the schematic shows. So what you see on the schematic is all the possible interventions that we can take for a given patient for the purpose of sepsis management. But we can't try all of them. We can just observe what actions or what sequences of actions the clinician took. And from these trajectories, we get to train a reinforcement learning agent to suggest the optimal sequence of interventions. And we call this kind of reinforcement learning offline reinforcement learning because we don't get to do these online experimentations. Now, it's possible that there may be settings where online learning is reasonable in the clinical context. So maybe, I don't know, like mouse models or things like that, but I suspect it would be a pretty hard IRB to implement something like this or like online reinforcement learning on real patients. Okay, one example of offline reinforcement learning is a paper where the authors trained a reinforcement learning model to manage and treat patients with sepsis. In this example, the state that the agent observes is features including demographics, vitals, the Alexhauser comorbidity index, as well as like a number of other things that were extracted from electronic health records. The actions that the agent could take was to pick a dose for IV fluids and a dose of vasopressors. And these doses were discretized into 5 values each, giving a total of 25 possible actions that the agent could take. And the reward was that was given to the agent was a score of 100 if the patient survived and negative 100 if he or she died. So obviously higher numbers are better. The conclusion that the authors made is that the policy prescribed by the reinforcement learning agent led to low rates of mortality, and in some cases even lower than the observed clinician treatment plan. I will give here an important disclaimer that reinforcement learning models are notoriously difficult to evaluate in an offline setting, meaning it is hard to estimate how good a treatment plan is that the reinforcement learning agent suggests. So I would suggest taking this conclusion with a grain of salt. And I think this disclaimer is a good segue into the second part of the talk, where Karandeep will expose some of the limitations of machine learning models. But before handing things off to Karandeep, if you're sitting here and thinking, I want to dig deeper than the basics, and I even want to jump into current research, especially as it pertains to healthcare, there are a couple of conferences that I wanted to put on your radar that are in the machine learning side that are entirely dedicated to healthcare applications. These are the Machine Learning for Healthcare Conference and the Conference on Healthcare Inference and Learning, which is otherwise known as CHIL. And of course, there are a bunch of publications on the medical side that I think this audience might be more familiar with, so I won't enumerate them. And there are smaller workshops in the 2 biggest machine learning conferences, NeurIPS and ICML, that are dedicated to these applications. So there are a number of ways to jump in. With that, I will hand it off to Karandeep to dismantle this rosy image that I painted about machine learning.
Thanks, Maggie. So, thank you for that overview of machine learning and kind of talking through supervised, unsupervised reinforcement learning. One of the interesting things is that, when you are thinking about machine learning and you show up in a healthcare operations setting, the first question that usually comes up is, when you bring up machine learning is, wait, why are we even talking about machine learning at all? Like, why is that even something worth paying attention to? And what I usually, do in an effort to try to communicate this is put this in the context of like a learning cycle or kind of a quality improvement cycle. And the way I view the role of machine learning inside of a learning health systems approach is really that it helps you identify patients who are high and low risk at scale. So, if you're a clinician, you walk into a patient's room, they've got an elevated heart rate, their blood pressure is dropping, they look pale, they're breathing heavy. That patient is sick and they need additional attention. And that's someone that you may call a rapid response on, or you may call a code on, even depending on kind of which direction things are headed. But if the question comes up, who are the 20 sickest patients in the hospital right now? That's not something that you personally can answer without help from an algorithm that can score patients and kind of assign risk to them that you can then use to allocate resources. So obviously it's not enough to know who the sickest patients are. You have to do something to be able to improve care and allocate resources more effectively. And usually what we do is we take the highest risk patients and we throw more resources at them. We treat them more aggressively. But occasionally when we have resource constraints, we have to think about reserving lower acuity care and kind of removing some resources for lower risk patients. So last year, when a lot of discussion was happening around opening a field hospital, what we were essentially saying was patients who needed to go to a field hospital were those patients who we felt probably would not need ICU level care and therefore could safely, hopefully, go to a lower acuity setting. And ultimately, to do any of this work, you have to have infrastructure and electronic health record. So we'll talk a little bit more about that, but we'll move kind of and talk about decision support alerts and kind of why they matter. So machine learning can only affect care if you link it to some kind of clinical workflow. And there's many different ways that the output of a model can be operationalized. So, some of the more interruptive ways are like pages or secure texts. You can be at lunch and get a page that a patient is deteriorating and needs your attention, and you can drop everything and kind of go. Another type of alert is a clinical decision support alert, and that can mean a lot of different things. Most commonly, this is what people refer to as kind of the pop-ups that come up when you're viewing a patient's chart. These pop-ups may happen in response to an action being taken, like you prescribing something or you ordering a test, or it can just kind of pop up when you're in the electronic health record. But there's a whole variety of ways that you can take model output, link it to some kind of piece in the electronic health record that then links to a clinical workflow and leads to a change in action that hopefully is a positive change. So folks kind of thinking about this, especially if you're not in health, you might say, well, don't clinicians make their own medical decisions? Don't they like look at the situation, assess it, and decide, what should we do? So for example, if your electronic health record said you should dose this antibiotic daily, the clinician should think about it and say, well, I was trained to dose it twice a day and I always dose it twice a day. Why would I listen to the computer? So, is this actually the case? Do the clinicians listen to the electronic health record, or do they kind of trust their own instincts? And you would be surprised that to a surprising degree, clinicians are just like anyone else. They want the fewest clicks to get to where they need to go. And so interestingly, this was this really nice case study at Brigham and Women's Hospital where David Bates and colleagues were looking at prescribing of ceftriaxone. And ceftriaxone is typically prescribed daily, but in this case, the default order set had it being prescribed twice a day. So 80% of people were just prescribing it twice a day because that was the default order. So on day 6 on this thing where you see that blue line, they decided to change the defaults, right? So you could think of this as a form of non-interruptive decision support because you go to write the order and behind the scenes, a rule says, instead of showing them twice a day, let's show them once a day dosing as a default. And almost overnight, 80% of clinicians started prescribing daily ceftriaxone. And what's funny about this is that they had actually tried all kinds of clinician education, all the kind of usual interventions, but overnight they started saving $200,000 a year from this change, which was actually medically more appropriate anyway. So we know a lot of things about what makes for effective decision support, and people often cite the 5 rights. So, you want to deliver the right information that's hopefully evidence-based. It's going to, lead to someone changing their mind. You want to deliver it to the right person. Sometimes that's the physician. Many times it's not the physician. It could be a nurse. It could be allied health professional. It could be a tech. It could be the patient sometimes. And you want to deliver it in the right format. So, you want to reserve your alerts for things that need an alert. Otherwise, you want to handle things silently when you can. You want to deliver it through the right channel and at the right time in the workflow. So you don't want to deliver some piece of information to a clinician at a time where that thing isn't even really up for discussion. That decision has already been made. It's kind of too late to deliver that information now. And interestingly, effective decision support should anticipate needs. And I think, although this paper doesn't explicitly say it, this is kind of where I think about what the role for machine learning can be. If an optimal clinical decision support system should have the capability to anticipate the latent needs of clinicians, then it makes sense that a lot of these latent needs can be identified through risk prediction, particularly when there's so much information, you're in a very information-rich environment where clinicians might miss something because of the sheer volume of information that they're having to sort through. And as many of us know, especially those who are clinicians, clinical decision support brings unintended consequences. And 2 of those consequences that we talk a lot about, probably the most popular one that folks know of is alert fatigue. This is from a paper by Joan Ash and colleagues, where they did some field work to look at, what are some of the unintended consequences of decision support systems. And this is straight from the field notes that went into the paper, that there's several examples of how alert fatigue happens. So like most drug interactions, 2 medications that interact with one another, those alerts are just completely ignored. Alerts that try to give you weight-based dosing, those are often, because weights often can't be entered into the system, clinicians have to decide, do I give this drug at the wrong dose or not give it? And the rigidity of our systems can be problematic, especially when it comes to these kinds of things that require a lot of dynamic information to make adequate or accurate decisions. We over alert, and so basically we either need to put our teeth into these warnings or don't do them at all. And I thought this was a really nice example that because of so many alerts and pop-ups, the docs may blithely just click OK without a reason and not even read it. And I think that has to do with the fact that you're trying to do a task, the decision comes up at the wrong time, you're not ready to handle that decision, so you try to ignore that decision so that you can take care of the task that's in front of you. Interestingly, as we start to get more algorithm-based rules or more complicated rules like machine learning models, we also incur some technical debt. We now have to not just make sure our rules work, but we have to make sure that our rules are up to date, that they continue to work, that they don't stop working, because many of these kinds of more advanced models, while they can be more accurate when they're trained, they can also be more prone to overfitting as other things are changing in the environment that lead to the model kind of going off the rails over time. So linking machine learning to decision support, I think conceptually is a very powerful tool. Our rapid response teams in the hospital at Michigan Medicine have access to, actually right now they have access to 3 different deterioration models that they're comparing that rescore patients as often as every 15 minutes. And they can use this information either in real time or as just a rounding list to decide which patients they should be proactively checking in on to try to stabilize patients, to either get them to the ICU more safely or to prevent them from needing to go to the ICU. So this is just showing you how dynamic these scores can be. These are 4 different patients, 2 of whom needed to go to the ICU at the top, 2 of whom didn't. But you can see that, as a clinician, it can be a lot to try to manage these kinds of scores when they're kind of going up and down very acutely. There is some evidence that machine learning decision support can save lives. So there was this really nice paper by Gabriel Escobar, Vinny Liu, and colleagues out of Kaiser, showing that in this deterioration model that they were using to identify patients who might need to go to the ICU, when they implemented this program, the mortality in the group that got the alert was comparatively lower when you adjust for relative risk. So this was kind of one of the most high-profile examples of a decision support rule linked to a model actually improving patient outcomes. Now, that said, decision support rules don't always work. I thought this paper by Downing and colleagues out of Stanford was really interesting. They tried to deliver sepsis alerts and to try to change a whole variety of clinician behavior, not just in the ER, but also in the inpatient setting. And their primary, secondary outcomes, pretty much they couldn't change anything. And one of the things they couldn't change, surprisingly, was the amount of fluids given, because how much fluid you're supposed to give is like built into the guidelines that everyone subscribes to. So when they went and asked the clinicians, like, why didn't you give the recommended amount of fluids? Only 2 of the physicians had given them, and the physicians generally reported that, yeah, we agree with the guidelines, but when it comes to our patient, we're worried about giving too much fluid, or we feel like they need fluid, but not the recommended amount by the guidelines. So, it can be interesting to see that even when an alert might be guideline recommended, it actually doesn't match what clinically physicians deem to be appropriate at the bedside. So, these kinds of evaluations can get very tricky, particularly with proprietary models. Sometimes you evaluate a proprietary model and you get performance very similar to kind of what was reported by the model developer for the use case that you plan to use it for. And other times you look at your use case and you take a model that reportedly looks good on paper, and when you check it, it looks substantially worse. And so these kinds of models I think are tricky because many of these don't have independent publicly available literature. Many of these predictors are not publicly available, and so you're dealing kind of with having to look and see how these things work with to some degree, incomplete information. And metrics aren't everything when it comes to machine learning driven alerts. So this is time zero here represents patients deteriorating and going to the ICU. And each row here is a patient. Each tick mark is when that patient exceeded the alerting threshold, they got a tick mark. So not all of those would actually be real alerts, because you would probably suppress some of those alerts. But just to give you a sense of how this might actually look like when you deploy it on real patients. And you can see that there's a bunch of patients where who deteriorated, who were identified many hours before deteriorating, where you might have been able to do something. But there's also a substantial number of patients where, yes, the model detected that they were deteriorating, but they detected it, they got detected so last minute that it begs the question, was it really useful in these patients? Even if you got a high area under the curve, high apparent performance, your model is only useful if you can deliver information in a timely manner such that you actually can prevent the outcomes, an adverse outcome. So machine learning alerts are also very brittle because they can change over time, because a lot of these alerts are trying to predict practice patterns, or they're using practice patterns as predictors. And as practice patterns change, they can also dramatically change. And in this case, this is a theoretical example where an acute kidney injury model got totally miscalibrated when it was trained 10 years ago and starting to be used more recently. Again, theoretical because this wasn't actually deployed. But we've seen this happen in the real world also. This was a paper that I co-authored with colleagues at a variety of different institutions, looking at data set shift, which is the phenomenon of a model not being able to predict well in a setting due to changes in our underlying technology, patient mix, or clinician behavior. And in our case, we actually had shut off our sepsis model during COVID because of how much excessive alerting was happening during that time. I mean, we just didn't have the capability to handle it. So you have to be able to respond to these alerts and figure out, whether you need to change your alerting threshold or whether you need to turn these alerts off. And alerts don't happen in a vacuum. So people don't just get one organ being sick. They get sepsis, their blood pressure drops, they start to deteriorate, they develop acute kidney injury from the low blood pressure. So anytime you're thinking about deploying one of these, you have to know what is the context in which you're deploying it, because you might suddenly be sending multiple alerts on the same patient in a way that would be disruptive to clinical care. So I won't go into this slide. I'm just gonna, this is kind of a funny thing that really just illustrates the point that clinicians think they understand this alerting thresholds, but they actually don't. This is, I'll share the slide so you can look at this later. And I also won't go into this, but talking about, there's theoretical knowledge you can use to pick optimal alerting thresholds that come from clinical trade-offs. And similarly, I think I'm co-organizing a symposium with colleagues at NYU and Parkland on implementing and evaluating machine learning models. It's called the SMILE Symposium. Feel free to check it out and register. Registration is free and the information is here. Thank you, and I'll turn it back over to Vicky for our Q&A.
Great, thank you so much. That was a really great presentation by both of you. We do have a couple questions that have come in. I'm gonna ask the first one. So this person is curious about the validation of reinforcement learning-based recommender systems. What are best practices and pitfalls one might fall into when validating RL decision-making support systems that were trained offline? Thoughts on that?
Yeah, it's a really good question, and it's a really hard question to answer because I think this is something that we've struggled with a little bit in the machine learning community. I am going to answer this in a somewhat indirect way by highlighting what the problem is and what some solutions were. So let's say that the observed data that we collect from some hospital says that 10% of the high acuity patients don't get any treatment. If my reinforcement learning agent says, I think the best policy is to not treat 90% of the high acuity patients, then what I would do to evaluate that kind of policy is I would take the 10% that I observe in the observational data and upweight them such that they look like they make up 90% of my data. So in other words, we deploy inverse weighting schemes to statistically manipulate the observed data such that it looks like it came from, or it is it's similar to the policy that the reinforcement agent learns. That's the common way to do that, these like weighted importance sampling schemes. But the issue comes when my reinforcement learning agent says, don't treat 90% of the high acuity patients, but in the hospital, 0% of the high acuity patients don't get the treatment. In other words, we don't observe any examples of similar to what the reinforcement learning agent suggests. In that context, it is very hard to just evaluate this policy from the observational data. And in fact, like we call this a non-identifiable case or non-realizable, something like that. In these cases, machine learning can't really help us, or we can't really evaluate this policy. So what I would say is, like, for people who are working in that setting, is to like really look at what the policy that was suggested was, and really make sure that your importance weights are not 0 or 1 in some cases. So 0 would say that none of the patients that I observed in the observational settings mimic the policy, or 1 would be saying 100% of my patients mimic the policy. So this is kind of like similar to the overlap assumption in causality, if people are familiar with that.
Yeah, so I'll just briefly add to that and say that the ethical challenge of taking an offline trained RL model and running it online is that every decision it should make should ideally have equipoise, right? So you wouldn't want to give it, if the algorithm says I want to give 8 liters of fluids because that's what I think is the right thing to do, it might learn that that's not the right thing to do after that patient has met their demise. But we don't have that flexibility. Every decision it makes should have some equipoise. And so it's really hard to study these online, and you can validate them with offline data, but then all the issues come up that Maggie brought up, which is if your offline data only has appropriate care, doesn't have inappropriate care, then how can it differentiate appropriate from inappropriate care?
Yeah, and I think too, something that you had mentioned, Karandeep, that just kind of struck me was, with COVID, you actually had to turn some of the alerts off because it was just so many. And so I'm wondering for our clinicians that are in the audience, I can see where, at being in pharmacy, like there were so many alerts. We get drug interactions alerts all the time, and we know that clinically they don't matter. On paper, yes, they matter, but clinically they may not be that great of a risk. And so for a clinician, how do you maintain kind of the vigilance to do no harm when things change in such a rapid at such a rapid pace?
Yeah, one of the unintended consequences of CDS was the fact that you have to maintain it. And who does that maintenance? Many hospitals, because of the sheer number of like interaction databases that you have to maintain, essentially outsource this. And there are different levels of severity of alerts, but I'll say when I was a nephrology fellow not that long ago, I still remember every day having to dismiss an alert where the multivitamin was interacting with vitamin D. And it was like, come on, like this is not, do I really need to go through this every single time? So, just one of those things where there's a really nice paper by Aaron Kesselheim, I think, that talks about the legal implications of turning alerts off and what that might mean, because there's a human in the loop and a learned intermediary. So I would recommend that paper for folks who want to read more about this.
So we have 2 questions that are somewhat related, so I'm going to try to ask them together. The first is about for clinical adoption of models, how important it is for models to be transparent and published, and also if clinicians struggle with thresholds, does publication of models actually help with adoption? But the other comment that kind of goes along with this has to do with data biases influencing the models, especially around race, gender, sexuality, class lines, that sort of thing. And how do you, the risk assessment models being used unfairly in an actuarial insurance adjusting setting. So these are two really, really big topics. And I just want to make sure everyone on this call is aware that in January, the bias issue is something that we're going to be discussing as well. So please stay tuned for that. But okay, I'm going to be quiet now and let you both answer.
Maggie, you want to go ahead?
Sure. Maybe I'll just mention one thing and then maybe you can like add to that. The question, I really like that question about bias, because I think one thing that I dislike is that people will assume that because it's a computer or because it's something that came out of a computer, it must be objective, like numbers don't lie, right? But that's actually like so far away from reality. Garbage in, garbage out is a very, very reasonable concept here. Like if we present to the computer data that reflects biases in the insurance claims, like biases due to lack of access, lack of quality care, that 100% gets reflected in our models. So our models will perpetuate biases if we are not careful. And I think there exists some work right now about like, how do we, this is an area that I actually do some work in, how do we create models that are invariant to these biases that inevitably exist in the data. So I think a good way to address this is to sort of accept that the data is biased and then try to build models that are not unaware of this. Try to build models that are aware that there is bias in the data and that we counteract it like so almost like preemptively, or we take a more defensive approach. But yeah, I don't know if Karandeep, you have more thoughts on this.
Yeah, I'll touch on both questions. So I think for Vikas's question, hey Vikas. Vikas, by the way, is a co-organizer of our Smile Symposium. So I didn't plant him, but I appreciate the question from you. So I think it's really important. There's two things here. Is the evaluation transparent and published? Is the model transparent and published? Many times in healthcare, the evaluation is transparent and published, and the model is nowhere to be found. More so than I would say in non-healthcare settings. It definitely happens in healthcare settings. My personal thing is that, for a lot of proprietary models, neither is transparent and published, or if it's transparent to very specific users, but not to the patients to whom we're ultimately accountable, in the general public. So I personally think, that transparency at the very least about what you include in your model is a starting point for discussion. And I think we're not even there yet. So I think we should start there before we aspire for kind of more kind of transparency and accountability. And this gets to the issue of data bias. You can't react to issues if you don't even know what's going into your model. And simply excluding predictors doesn't solve problems. Our data is a reflection of our reality, which is a reflection of all of the inequities that are there. So you can talk about removing race, including race, removing gender, including gender. At the end of the day, it won't matter. If our society is divided up unfairly, and that can be detected in the data, it's going to be detected in the model, regardless of what you include or exclude.
Great. We have two other questions that I'm hopeful that we'll be able to get to. One has to do with inappropriate care outcomes being added to supplement offline learning. Can you add a bunch of cases, given the 8-liter example that you gave, where 8 liters is actually given and labeled as a patient death to kind of provide limits to some of the offline models?
I think that could be a way to address this. The problem is, or not the problem, the challenge is that you are going to have to think of all the ways that this can possibly fail and augment the data with all the possible ways that it can fail and then label them with patient death, which that gets challenging because when these, like I talked about state and action pairs, like these states are sometimes super high dimensional, like 5,000, 6,000 variables. So you have to think of all the possible state combinations and all the possible bad actions that you can take for that state and augment the data with them. But data augmentation is a good way to think about this.
And then last question, this one is for Maggie. Could you talk a little bit about the risks and dangers of using unsupervised learning in clinical settings, and when should we not use unsupervised learning?
I think similar to the issues that we just talked about, whenever there are biases in the data, and whenever the data that we are using are not are reflective of poor or are reflective of systemic biases, then I think unsupervised learning, or even generally any kind of learning, is tough, and we should be vigilant when we're using it. Specifically for unsupervised learning, I think unsupervised learning might be a little bit more, specific types of unsupervised learning might be a little bit more sensitive to parameter choices, meaning like what we decide is the number of clusters a priori if we do decide. So you might end up sort of combining two groups accidentally or things like that. But I think generally the limitations are similar to the general machine learning. I don't know if Karandeep, you have other thoughts on this?
Rashawn already knows all my thoughts because I'm actually one of the advisors on his dissertation.
Another
we had one question
claim.
we had one question that just came in, and I see we have about 3 minutes left. So this person is wondering if you can elaborate on how you can identify that the data being used is potentially biased.
Okay,
so in January, we're going to find out. No.
Yeah.
This is a great question. I think there's a lot of things people try, right? There's different kinds of unfairness metrics, fairness metrics that you can calculate. Now, that's not for the data, that's for a model fit on the data, but sometimes the model is a representation of the data, and you can explore the model as a way to understand what's happening in the data. So there's various unfairness metrics, and depending on what a model is going to be used for, different metrics might be more applicable. So, I think of it like if you were thinking of a black box warning, if you apply every unfairness or fairness metric, every model is unfair by some metric. The question is, what do you intend to do with that model? And as long as you have the assumption that everyone is going to only use the model to do the one thing that you think people are going to do with it, then you can at least try to identify where that could be the case. But we often don't think of it. Like, the example from nephrology recently, where the formula for kidney function, that was designed to just capture your kidney function. We didn't think it was being designed to capture who's an adequate or appropriate transplant candidate, but that's how it's being used, and it's introducing inequity because of that. So it's a very close link between what the data is being used for and what fairness metrics might apply to that situation.
And I think just to add to that a little bit, I think, you certainly brought this up. It also, is clinical judgment, and that, even though it is machine learning, it's not always fallible, or it's not always perfect. It is fallible, and humans are fallible as same. And so it's kind of taking a big picture look at what exactly is going on in using this as a tool. So thank you all. We are now at time. This has been a wonderful presentation, 2 presentations and a wonderful session today. Great questions and answers. Thank you everyone for attending. You will all receive a link to the recorded webinar when those come out. And then we'll also be sending out an evaluation, because we would love to hear from you about further topics that you are interested in. And if you are not doing so already, I highly recommend that you follow Karandeep on Twitter. That he is one of the people that I do follow. If Maggie, I don't know if you have a Twitter handle that we can follow as well. We would love to follow on, because I think it's always interesting conversations, that not being an expert in this field, to hear your thoughts on this is a really great. So thank you. Keep tweeting. And I hope to see you. Our next session is going to be in early December. And I hope to see you all then. Thank you.